to your lecture. In this video, we're going to go through chapter 15 from your textbook, the urinary system. So first of all, let's talk about the kidney. The urinary system is responsible for regulating your internal environment. It is one of your buffers. Your lungs are your primary buffer system that will buffer your blood, therefore the pH of your entire body, but then the kidneys do the back end stuff. A couple important things about the kidneys. They are what we call retroperitoneal, and they sit within a renal fat capsule. Because they are retroperitoneal, they sit behind the peritoneal cavity within the lower portion of your abdominopelvic cavity. So they kind of sit outside of everything. And as we learned, some of the digestive organs have pieces or parts of them that also sit retroperitoneal. Now, because of this, that fat capsule, the kidneys will lie within and be surrounded by perirenal fat. That's going to help with insulation, with thermoregulation around them, but a lot of protection there. We understand, I think, fairly well that they do remove waste, but the waste comes from the blood. A lot of us associate the kidneys with water, yes, and urine, yes. But what they're doing is they are filtering the blood, taking out the waste, maintaining the regulation of pH. They will maintain blood pressure. Actually, when we are attempting to regulate someone's blood pressure, we're looking heavily at what the kidneys are doing. So some other interesting things about the urinary system. The right kidney will sit a little bit lower than the left one, and this is due to the presence of the liver. The liver primarily located on that right side of your abdominal cavity. The kidneys that right kidney is pushed down a little bit. Also, another portion of the anatomy of the kidney, due to how the abdominal aorta and the vena cava, the inferior vena cava, will run through that abdominal cavity. The left renal vein and artery, primarily the vein, it's going to be a little bit longer than the right one. On top of the kidneys are your adrenal glands. The kidney has an area where the renal artery, renal vein enter and exit, respectively. But also in the same area, the ureter, which will drain the urine from the kidney, exits, and this area of the kidney is called the hilum. Each kidney is to have one ureter, which will then drain urine into the urinary bladder. The bladder, those ureters come down to the posterior inferior portion of the bladder, actually, how it's sitting within the body and how it's regulated. So when we look at the inside of the kidney, like we've experienced with other organs, we did see the hilum of the lung. There's the hilum in the lymph nodes, okay. Again, the hilum is where the artery, vein, and ureter will enter, exit. The kidney will be surrounded by what's called a fibrous capsule. We saw that also in the lymph node. They're very similar to the construct of a lymph node. They will have a cortex, which is the outer portion, and then they will have a medulla, which is the inner portion. Within the medulla is where most of the structures we can identify are located. Within the medulla, we'll see structures called renal pyramids. At the base of the pyramid, kind of like the pointy part, that's called the papilla. There will be an area located at the base of the pyramid, or this papillary region, called a minor calyx. We will have a minor calyx from each pyramid then join or merge into what's called a major calyx. It's just a larger area. They're hard to define. The major calyces then will merge into what is called the renal pelvis. And this is going to be the larger area within the medulla of the kidney where the urine, after the blood has been produced or produces a filtrate. The filtrate will be refined further into urine. The urine will find its way to the renal pelvis. From the renal pelvis, the urine will exit via the ureter. So blood supply wise, again, renal arteries transport blood to the kidneys. The veins will take it away. Nerve supply, they will have nerve fibers from irregular mesh outside the renal artery. And we will see, again, renal arteries, veins, nerves, and the ureter connected to the kidney at the hilum. The kidney will typically have one renal artery, one renal vein, but we are going to see abnormalities or variants in these regions. You can have additional arteries and veins going into the kidney. There's something called a horseshoe kidney, and we're seeing a picture of it within our PowerPoint. This will be in your textbook as well. Or maybe someone's only born with one kidney. Okay, that's functional. You can absolutely survive with one kidney. Or maybe you'll have two ureters. Okay, the nephron, this is the functional unit of the kidney. The nephron does have a delicate blood supply and is the microscopic part of how urine is created. It has what's called a renal corpuscle and a renal tubule. The renal corpuscle is comprised of something called a glomerulus. The glomerulus, which is again within the renal corpuscle of the nephron unit, is a cluster of capillaries. It will be surrounded by a glomerular capsule. So this picture does a great job here. Now within this picture, it gets detailed into other cells within the nephron unit. So we have coming into the capsule, this space, okay, surrounding this capillary bed. It will have an afferent arteriole bringing blood supply into the capsule. And it will also have an efferent arteriole, which after the blood makes its way through the capillary bed, it will leave the capsule via the efferent tubule. Within this capsule, some things we want to note. There are specialized cells called podocytes that have a particular job. There are other cells within this too. So the blood comes in, travels through this capillary. What will be produced is filtrate, okay? It will pull things out of the blood traveling through the capillaries and leave in what's called the proximal convoluted tubule, and that's right outside of the glomerular capsule. The proximal convoluted tubule, then again, right outside of that capsule, will lead into what's called the nephron loop. The filtrate will make its way through a distal convoluted tubule and then into what's called the collecting duct. And this is where the magic happens. Okay, after it makes its way through all of these things, you will have urine produced. The nephron loop, you can see by way in this picture. Let's look at some other things here 1 second on this picture, which are relevant. So we can see a dotted line here separating the cortex of the kidney from the medulla. So this whole unit, okay, has parts that extend from the cortex and then other parts of the nephron that will extend into the medulla of the kidney. We have, again, coming into the capsule, we can see parts and pieces of the proximal convoluted tubule. Proximal tells us that it's going to be close to the capsule. Then we have the distal convoluted tubule. Again, the nephron loop. If you look at the nephron loop, also we have a descending and ascending branch or limb of the loop. They are going to do different things. Okay. Also, the descending loop of the nephron is going to be thinner walled, whereas the ascending loop has a larger portion of it that's thicker walled. And again, this has a function and a purpose. After it comes back up into the cortex, it will reach the collecting duct. You can see also all around the proximal convoluted tubule, the presence of what's being called paratubular capillaries. So even though the large portion of the filtration of blood happens within the capsule, as the filtrate is produced and runs through these tubes, there are capillaries wrapped all around them, which have high significance also with doing further production of urine from the filtrate. We have something also around the nephron loop called the vasa recta. Again, it's like this interwoven system of vascular supply, both arterial and venous, doing what they need to do respectively. When we talk nephrons, we have to understand there are cortical nephrons. These will have a shorter nephron loop, and then we have juxtamedullary nephrons, which have longer nephron loops. Only nephrons that can produce high concentrated urine are the juxtamedullary nephrons. We mentioned the efferent arterioles. These will transport blood out of the glomerulus. They will connect to the paratubular capillaries, which I mentioned, wrapping all around the tubes, which will eventually give rise to that vasa recta, which I mentioned also. Now, how blood flows through the kidney. The blood will enter the kidney via the abdominal aorta, then enter the renal artery. It will reach the afferent arteriole at the glomerulus, meaning it's bringing blood into the glomerulus. Then the blood will flow through the glomerular capillaries. About 20% of the blood will enter the glomerular capsular space. The blood will then exit the glomerulus through the efferent arteriole and enter either the paratubular capillaries or the vasa recta. The blood will reabsorb most of the fluid, not the waste, it lost within the glomerulus. Then the blood will collect within the venules, which will merge to form veins and exit via the renal veins. So when we're talking about how the urine is actually formed, this is a simplified picture, but it's really helpful. So we can see that we have blood coming in on the left side of the slide through the afferent arteriole, entering the glomerular capsule. This is, again, the renal corpuscle. As the blood gets filtered within here by the specialized cells, one being the podocytes, like we mentioned, the filtrate will continue into the proximal convoluted tubule, nephron loop, distal convoluted tubule, into the collecting duct eventually. Water and solutes will move from the capillaries into the glomerular capsular space. The glomerular filtrate, which is the name for water that reaches the capsule, needs to be understood, the difference in the nomenclature. It will have a filtration membrane, capillary endothelial cells, a basement membrane, and podocytes. The glomerular filtration rate, or the GFR, is talking about the rate, the speed at which blood can be filtered freely. If you get a blood draw with a metabolic panel, they're going to look at your glomerular filtration rate, which, depending on circumstances within your body, you can tell a lot by. or you can tell a lot about what's happening metabolically if you look at this number. So the hydrostatic pressure is something that will push water from an area of high pressure to areas of lower pressure. When it's in the glomerulus, the hydrostatic pressure in the capillaries will equal the blood pressure. It will have a higher than the pressure in the capillaries, in most capillaries. When we're talking osmotic pressure, this is created by the dissolved substances within water. So the blood in the renal corpuscle has higher osmotic pressure than the filtrate does. The proteins are present only on the blood side of the membrane, or should be. This is why large amounts of protein in urine, we know something's up with membranes within the kidney because of that. Molecules that are small enough to cross are present in equal concentrations. So when we are talking filtration, like what assists it into doing what it's supposed to do, if we understand that within that capsule, there's a certain amount of hydrostatic pressure and a certain amount of osmotic pressure that should be present. If it becomes too much, we can damage these, which is the danger. So if you have high blood pressure coming into the capsule that the kidney can't regulate long-term, which it can do some localized control of that, but it can't do large amounts of blood pressure control for extended periods of time. So the danger in chronic hypertension is that we damage this whole filtration system. So the reason that we need to understand the control rate of glomerular filtration, if something is too low, the waste and excess water will build up. If something is too high, dehydration and other important substances are lost. Control mechanisms, the blood pressure in the glomerular capillaries can be controlled by hormones and the sympathetic nerves to the kidneys. Remember that those adrenal glands sit right on top. So the medulla of the adrenal glands is that's where catecholamines are produced, your epinephrine and norepinephrines, which are responsible for control of the sympathetic nervous system. So high fight or flight situations are going to control this rate of filtration and either make it produce more or less, depending on what the tone is. And then particular hormones will help regulate the control of this rate as well. When we talk about reabsorption, sodium, we have to understand the role of sodium excretion, something called secondary active transport, and osmotic pressure. When we're talking about reabsorption, sodium is the most abundant ion in the filtrates, and as the proximal convoluted tubules will reabsorb substances from it, the sodium is actively pumped out of the tubular epithelial cells by sodium potassium pump proteins. These carrier proteins will use the ATP to move sodium from the cells into the interstitial space that surrounds the peritubular capillary. Secondary active transport, the energy of one substance is used by a protein to pump the other substance in the opposing direction. So glucose, amino acids, some ions and vitamins will enter the cells from the tubules by means of secondary active transport with sodium. These valuable substances then spread out of the cells on the other side and diffuse into the peritubular capillaries. When we're talking osmotic pressure, the positive charge on the sodium ions will tend to draw the negatively charged chloride out of the tubule and into the peritubular capillaries. The active pumping of sodium into the interstitial space and its diffusion into the peritubular capillaries will create a relatively high osmotic pressure in the capillaries and in the interstitial space. The high osmotic pressure will draw water out of the tubule through the cells and into the interstitial space and the capillary. There are aquaporin channels in both sides of the cell that will give water an easy way to enter and exit the cells. Thus, the active pumping of sodium will provide driving force for the reabsorption of glucose, amino acids, vitamins, chlorides, other ions, as well as water. There's something that is relevant here. It's called sodium drag, okay? When we have ions moving in one direction due to the polarity of charged particles, water moves with it. So in this picture here, and this is in your book on page 503, it shows you the movement of ions and how they move in or through or across the cells within the tubule. When we talk about secretion then, okay, secretion is something that's pushed out, right? So active secretion, this is when urea and uric acid are pumped out of the capillaries and into the renal tubule. This will use chemical energy to move molecules. Unlike filtration, which is a passive process, secretion will use ATP. The act of pushing of molecules into the lumen of the tube is called tubular secretion. The lumen will contain fluid that will be eliminated along with hydrogen ions, bicarbonate, and some drugs. Two molecules that are actively secreted again are urea and uric acid. Urea received its name because it was first discovered in urine. Uric acid, which is made of 2 urea molecules and a few linking atoms, was first discovered in kidney stones. The normal protein breakdown will produce amino acids. The amine group, or that NH2 group on each amino acid, can react with hydrogen, which is plentiful in the body, to form ammonia, the NH4. Ammonia is highly toxic. Fortunately, the liver will convert the amine group into urea and uric acid, which are much less toxic. Because these molecules are secreted into the filtrates, and because most of the water in the filtrate is reabsorbed, urea and uric acid are considerably more concentrated in urine than in the rest of the body. The tubular epithelial cells can also secrete hydrogen ions or bicarbonate ions to maintain the pH. Okay, the renal medulla, I already mentioned this, okay? So in this picture, we see where we have a portion of the nephron that's located within the cortex, and then a part that will dip down into the medulla. What we need to notice here are different parts of the loop, which I already mentioned. So here's our nephron loop collectively that dips into the medulla. We notice the flow of filtrate. We also notice thick portions and thin portion to the tube. So in the descending loop, it's primarily thin. As it comes up into the ascending loop, the tube gets a lot thicker, and it will eventually end into the collecting duct. The collecting duct will continue and dump its product into a calyx. So a key to maintaining the state in the loop and We call this the countercurrent mechanism. It's called countercurrent because the blood flows down the vasa recta, then back past itself in the opposite direction. So capillary blood will grow highly concentrated as it travels down the vasa recta around the loop into the renal medulla because the osmosis will draw the water out of the capillaries. As the blood descends in the vasa recta, osmosis causes water to re-enter the capillaries. As a result, the blood leaving the vasa recta is no more and no less concentrated than it was when it entered, despite having passed through an area of very high concentrated interstitial fluid. The flow of the filtrate in the nephron loop is also considered a countercurrent arrangement because the filtrate flows down the descending limb, then up the ascending limb, adjacent to where it travels down. As with the vasa recta, the close proximity to these parallel pathways will help the kidney create and maintain high osmolality of the interstitial fluid in the deep parts of the renal medulla. When urine travels down the collecting duct through the deepest parts of the medulla, water can be reabsorbed from the collecting duct by osmosis into highly concentrated interstitial fluid. When this occurs maximally, the urine can reach, as stated previously, an osmolality of 12 milliosmoles because the water in the collecting duct reaches osmotic equilibrium with the interstitial space. When we talk about hormones, I mentioned that this is part of the control mechanism of how the filtrate comes into the glomerulus. So let's talk about the hormones involved. One of them is aldosterone. One is a NP or atrial natriuretic peptide, and one is ADH, antidiuretic hormone, which we've touched on at least two of them previously. So with aldosterone, this is a steroid hormone and it's produced in the adrenal cortex. A drop in blood sodium concentration or a rise in blood potassium will directly stimulate the secretion of this hormone. A decrease in blood pressure will also stimulate more aldosterone, but by an indirect mechanism. Decreased blood pressure causes greater secretion of renin, which is an enzyme produced by the kidney. Renin circulates in the blood and binds to the circulating protein angiotensin to produce protein called angiotensinogen to produce angiotensin. This is a polypeptide hormone in the blood that will constrict blood vessels and increase pressure. After binding to the angiotensinogen, the renin will cut the angiotensinogen into two fragments. One is angiotensin 1. This is an enzyme in the lungs. We touched on that previously. Appropriately named angiotensin converting enzyme. Or there's an enzyme called angiotensin converting enzyme, which will convert that angiotensin 1 into angiotensin 2. Angiotensin 2 then will stimulate the adrenal cortical cells to secrete more aldosterone. So again, aldosterone is activated for release when the body senses a drop in sodium in the blood, a rise in potassium, and then because of those two factors that it's monitoring, it will help regulate filtration rates as well as blood pressure, blood volume. Aldosterone then will act on those distal convoluted tubules and the collecting duct to bring sodium back into the body and secrete more potassium. Aldosterone then will cause a decrease in volume and sodium content of the urine and an increase in potassium content in the urine. The ANP, this hormone is made by the atria of the heart. It's released in response to an increased stretching in the atria, which will occur when blood volume is too high. So if there's too much blood returned, not enough filtered, or not enough water taken out, ANP will be produced. So ANP will inhibit sodium reabsorption in the collecting ducts, which will cause water to be reabsorbed. And then when we have ADH, we talked about ADH being stored by the posterior pituitary gland. Antidiuretic hormone, also known as vasopressin. This is a peptide hormone secreted by the pituitary gland. Blood osmolality will increase when a person becomes dehydrated because water intake is not kept up with water loss. ADH then will cause the collecting ducts to produce more aquaporin molecules and insert them into their own membranes. As a result, more reabsorption of water will occur in the collecting ducts, which produces more concentrated urine. When a person is very dehydrated and ADH levels are high, reabsorption of water in the collecting ducts is effective, so effective that the urine leaving the collecting ducts is extremely concentrated. ADH reduces diuresis. Diuretic drugs, which increase diuresis, are usually used for a person with high blood pressure. So once again, I already mentioned this. It's huge to understand the connection of the blood pressure and the kidneys. So yes, when we're trying to monitor and regulate blood pressure, we don't want damage to the heart or the vessels. However, we really need to look and see what the kidneys are up to. Remember that the ureters will connect each kidney to a bladder at the bladder's posterior wall. They are aligned with an epithelial tissue and contain a smooth muscle in the wall as well. The bladder itself is primarily composed of smooth muscle called the detrusor with an interior layer of epithelial cells. When it's empty, it will collapse, causing folds or rugae to develop, similar to the stomach. As a storage vessel, both organs, when they are empty, you can see the folds, again, the rugae. When it's full, you can't. A moderately full bladder may contain 500 milliliters of urine, and an extremely full bladder can contain 1,000. The trigone, this is ureteric orifice for each ureter. And also the area in the bladder that has the urethral orifice. So it is, let's see if we have a picture. There we go. Here we go to trigone. So we have the entrance of the ureters coming in the back, okay? And then the urethral orifice. You can see evidence in this picture of the rugae. And we are looking here at the male and the female, vastly different due to the urethra, the length of the urethra and the structures that it passes through. On the male, here's our bladder, our ureters coming in to the trigone area. Here we have our urethral orifice. It will pass through the prostate, which is why it's a giant concern or something to watch when a male goes through episodes or periods where urine flow is different or changed. The urethra on the male is long. The urethra on the female is a lot shorter due to the fact that the male urethra has to pass through the penis, whereas the female urethra, it's extremely short, but also what is part of the reason that a female is predisposed to bladder infections or urinary tract infections. Okay, one thing also I want to point out here on the bladder, this is the same as we saw in the digestive system. Okay, within the bladder, we have an internal urethral sphincter. We also have an external urethral sphincter. The internal one is going to be smooth muscle, involuntarily controlled, usually going to be regulated by pressure. The external sphincter is going to be skeletal muscle, voluntary control, and that's if you have to hold it, that's what you're holding, that's what you're controlling. So the excretion requirements then will require the contraction of the detrusor muscle. We can talk about some of the words for urination. Okay, micturition is one of them, voiding, urination. Okay, all words that let us discuss or understand urine excretion. Again, there has to be a relaxation of that internal sphincter that's autonomic, not within your control, and then a relaxation of the external sphincter, which is within your control. So when we're talking the neurologic process of how it works, at the lower end of the spinal cord, in the sacral region, we have some centers that will deal with the voiding of the bladder. This is ultimately controlled by higher, not like emotional brain centers, but like cerebellum, pons and medulla centers are going to have much to say about urination. Okay, so then when we talk about natal development of the urinary bladder in the system, within the 4th week, we have something called pronephros, mesonephros, and metanephros will develop, and these are structures that will then turn into our urinary system. In the 5th week, we have something called a ureteric bud, which will grow and develop to become the ureters, the renal pelvis, and the collecting ducts. The kidneys and the ureters will be formed from mesonephric ducts and metanephric tissue. We also have something called a cloaca. This is a common cavity into which the intestinal tract, reproductive tract, and urinary tract will all empty. By the end of the 7th week, the urogenital membrane has formed and has divided the cloaca into anterior portion, the urogenital sinus, connected to the reproductive and urinary tracts, and a posterior portion, which is the anorectal canal, which is connected into the intestinal tract. By the end of the 8th week, part of the urogenital sinus is growing wider to form the bladder. Intrauterine waste disposal. This is dealing with the chemical waste in fetal blood. What will happen is it will diffuse into the maternal blood via the placenta and disposed of by the mother's kidney and urinary system. The amniotic fluid gets swallowed. This is swallowed fluid that crosses the fetal gut into fetal blood. There is some that is filtered and excreted as urine by the fetal kidneys. So then in childhood, we're going to notice some changes as well. Newborn kidneys are lobulated. The GFR is significantly lower in the newborn as in contrast to an adult. The GFR will approach adult values by about a year old. By the age 2 or 3, then toilet training is regulated better. And that's why that happens. So the GFR will gradually decline again with age due to the loss of nephrons. Older adults are at higher risk than younger adults for chronic kidney disease. Urinary incontinence is part of it due to the loss of bladder elasticity, and there's an inability to fully empty the bladder. UTIs are more common in older women and men. So when we talk about urine, we have to talk about some of the testing. A urinalysis is the standard part of a physical exam. This section will describe some medical conditions and non-renal origin that will create abnormalities in the urine and eventually lead to kidney damage. So the physical characteristics of urine. The color should be clear and yellow, which is normal, cloudy, from urinary tract infection. And then the color other than yellow is the presence of, might have the presence of blood or vitamins, minerals, something from ingestion within it. The pH of urine should be around 4.5 to 8. And the urine has what's called a specific gravity, which is really like how much is in it, how much particulate is in it. Urine is to be 95% water-ish. It will have urea, which would be the most abundant solute. Potassium chloride, sodium, and other ions are typically present. There are other abnormal components that if we see in the blood, we're going to want to do more tests. This could be red or white blood cells, excess protein, and glucose. Again, the GFR, when we're talking GFR, we're talking about the rate of filtration, not what is filtrated. If a substance in blood plasma is easily filtered by the glomerulus and the substance is neither reabsorbed nor secreted by the renal tubules, then the rate at which the substance collects in the urine should be an indicator of GFR. Inulin, a non-toxic polysaccharide derived from plants, meets these requirements and it's been used successfully to estimate GFR. Although inulin is considered an excellent way to measure GFR, it is not routinely used. And it requires an infusion of inulin into the patient's blood. The most common way to estimate it is by measuring blood concentration of creatinine. This is a normal byproduct of muscle metabolism that is produced at a steady rate. Creatinine is freely filtered by the glomerulus, and to a small extent, the creatinine is also secreted by the tubule, which means that it is not a perfect compound for measuring GFR, but it provides a good estimate. Okay, so when someone gets diagnosed with diabetes, this is diabetes mellitus, tells us that there are large amounts of urine and they contain large amounts of glucose. This can be from the lack of production of insulin or the response to insulin, and that's the difference between type 1 diabetes and type 2. Type 1 is the destruction of the beta cells of the pancreas, therefore not producing insulin. And type 2 is the cells aren't responding for whatever reason. Type 2 generally can be corrected through diet and exercise, bringing down someone's pH, being more conscious of foods, and then remaining active. And a person can have both at the same time, by the way. So osmotic diuresis occurs due to abnormally high filtrate and osmolality. There are long-term consequences to diabetes, kidney damage, kidney disease, and renal failure. And the thing here is if it keeps trying to push glucose through the tubes, it's going to damage the nephron. And when you damage the nephron, then you're in trouble. Diabetes insipidus, this is large amounts of highly diluted urine. So insipidus comes generally from something up at the pituitary gland. So you're going to notice not only a lot of dilute urine, excess dilute urine when you have diabetes insipidus, when the ADH isn't produced right or you're not reabsorbing it. Chronic kidney disease diagnosed by evidence of kidney damage or low GFR can be caused by diabetes or hypertension. Again, that glomerulus, as the blood's coming in, has some local controls so that the pressure coming into the glomerulus isn't super high. Renal failure, this is most severe stage of kidney disease when they can't do their job and the waste products accumulate in the blood, which is going to create all kind of other symptoms downstream. Dialysis is usually the treatment and or kidney transplant. So really your kidneys fail to do the filtration and you have to go get it done externally. Peritoneal dialysis is where the diacylate is added to the abdominopelvic cavity, remains in the abdomen for an hour or more, will absorb the water and waste from the capillaries and the mesenteries. And the peritoneal membrane will serve as the dialysis membrane. Kidney stones, solid crystal-like masses form in the urine. They can be made of different things, but definitely, generally, I should say it's calcium, magnesium, or uric acid stones. They get stuck in the renal pelvis, the ureter, or the bladder. Lithotripsy is responsible for the breakup of the stone into smaller pieces. If you drink more water, okay, you have a less likelihood of creating the stones. Stones can damage the kidney as well, by the way. When we talk about urinary incontinence, this is the inability of those sphincters to hold it in. Okay, stress, incontinence, laughing, coughing, exercising, or heavy lifting, anything that's going to recreate that pressure on that internal sphincter created by weak pelvic floor muscles. You can work on strengthening the pelvic bowl or take a med, but I think you can do it through exercise. Urge incontinence, frequent and irresistible urge and need to urinate. This can be created by urinary tract infections or that enlarged prostate that I mentioned previously. A UTI or a urinary tract infection. This is when bacteria will enter the urethra. If the bacteria reach the bladder, this is known as cystitis. If bacteria travel to the kidneys, this can result in pyelonephritis. So we don't want a kidney infection, right? We don't want either one, but the potential for UTIs and bladder infection in females is relatively high or common, especially younger. It will create pain during urination. Frequency will be up, often fever and cloudy dark urine. Okay, that's it for the urinary section. We'll see